Hi, this is Dr. Janice Makela. Welcome to Q&A with Dr. Makela. Once again, we're here to answer your questions about cannabis and geriatric topics and hospice. I am your host, Dr. Janice Makela. I've been a doctor for over 20 years, working in geriatric medicine, hospice medicine, and have become an expert in cannabis medicine. I um, I'm not sure how many people are going to be joining us today. Um, I had a little bit of a glitch with LinkedIn today, this week. As you may know, I'm adding a Thursday evening Q&A so that people who maybe can't watch this video because they are working, at home working, or their office cannabis is blocked because it's not a safe topic to discuss. It's not legal, right? Those people um, might want to watch something in the evening. So I'm going to have on Thursday at 7 p.m. a Q&A live stream where I'm going to discuss cannabis and other things, any questions you may have about anything I know, geriatrics, hospice, of course. And I will be talking about that. And so I put both of those invites on LinkedIn for both today and for tomorrow evening, only to find out that LinkedIn only lets you invite so many people a week. And it's not per um, and it's not per event like I thought it was. It's a total. So would have had to split it up per event, and I put all of my maxed stuff for an event on the Thursday. And then when I went to go and do Wednesday, I didn't have any slots left to invite. So I'm not sure how many people got notifications about today's, but I'm hoping that some people remember from previous weeks and show up today. If you are here, feel free, throw in your name, say hi. Once again, great seeing you, everyone. Um, we'll talk a little bit about some different things. One of the first things I think I'm going to just talk about is is older people and cannabis use, specifically with dementia. As a dementia specialist, as a geriatrician, I have a lot of patients who have dementia at any given time. People come and are like, what can I use? And most of you probably know that dementia is a progressive disease where people lose their memories, but it's not just memory. A lot of times people can have behavioral issues. So maybe they don't remember you, or they don't remember time, or they don't remember stuff. But then the other things is they lose the ability to do things. And they lose them actually in the opposite direction that a child develops it. So if a 18-year-old can drive a car and maybe manage finances, and they're just, you're like, yeah, okay, they can, but I'd be a little bit nervous, right? As you go down, that's the first thing, excuse me, that's the first thing that with dementia people will lose is the ability to manage finances and drive their car. And so they might get more traffic tickets or accidents, or they might not be paying bills, whereas they used to always be right on top of things, or they used to know about all this stuff, managing their finances, or maybe they're scammed a little bit easier, that type of stuff. And so finances and driving are the first thing to go. Again, the thing that you just feel a little nervous about your 18-year-old doing, right? Now, as people progress, you get into issues of things that being able to trust themselves, being able to be by themselves for more than a few hours alone. Now you're into things that maybe maybe my high schooler can pick out some clothes, but if you had a middle schooler, maybe they need a little bit of help with that still. But of course, they can get themselves stressed. And maybe they can't cook dinner, right? You keep going down. Now you have like a first grader. They need to be cooked. You need to get the clothes out for them. Maybe they can put their own clothes on, and maybe they are able to do their own diapers and, change. They don't have diapers, right? They're potty trained and they can do all this stuff. As they keep going down with Alzheimer's, you keep losing these things. And so people lose the ability to walk. People lose the ability to change their own diapers or go to the bathroom on their own. They lose the ability to feed themselves. As that's actually one of the very late things is people need to be spoon-fed, just like a toddler, just like a baby, right? And again, that progressive loss of function. So you get that progressive loss of function, but along with that progressive loss of function kind of comes a progressive loss of what's going on. If you tell a toddler something, do this, they're going to maybe throw a tantrum, and you kind of expect that they're a toddler and their brain is trying to process, why is this person telling me? Now, take that to an 80-year-old with dementia, and you're like, Dad, you have to do this, or Dad, you have to do that, or Mom, you have to do this, or Mom, you have to do that. Now, that brain that maybe still remembers a little bit of who they were, remembers that they were a college professor once, remembers they were the parent still. It's like, why are you telling me this? I'm the parent. But they can't process all the stuff to realize what they've lost. They don't understand that they need that help. It can create a lot of behavioral agitation. Not to mention, you can see situations in people with dementia who, as they get more developed, again, that brain doesn't quite, the neurons aren't quite meshing. So you might be more prone to depression. You might be more prone to behavioral outbursts. In some ways, very similar to a toddler's tantrum, right? That continued decline of function, you can get behavioral outbursts. And the behavioral outbursts, can be very difficult for someone who's caring for someone with advanced dementia. And that, in fact, can be one of the reasons people wind up going into nursing homes is because the family members can no longer deal with all the behavioral outbursts. And then there's sometimes things like where people will just have emotional dysregulation, where the nerves leading to the emotions have been damaged by the Alzheimer's. So independent of stuff that kind of makes sense with people losing what they are, you can also have things like a pseudobulbar affect, which is a condition where people jump from crying to laughing very quickly. They go, all of a sudden, the world is ending and you're so mean to me and everything, and oh, it's all terrible. All of a sudden, they'll do something. They'll just go, ha, ha. And it's a little bit off. It's not like, oh, you just had a really funny joke laugh. It's a little disturbing, to be honest. I've seen it. It's not, it doesn't seem like a normal laugh, but it goes very quickly between these two extremes. And that's called pseudobulbar affect. There is a medication that can help with that. It's very expensive, but there are some things that, so there are some things that can be tied to Alzheimer's, to dementia, that have that are beyond just the normal loss. Now, and it's sad because you see someone and you love them and you care about them and you see their behavior is starting to change. And the question is, what can you do about it? Well, there's a lot of different things you can. I mean, number one is sort of support. Give them a quiet room. Just like, that toddler who's throwing the tantrum. You de-escalate. You take a breath. You don't raise your voice. You don't get angry. You de-escalate and you say, okay, let's talk. I understand you're upset. I understand you're angry. And they may be, blah, 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 I might be angry. I raised you, and you de-escalate it with soft tones. And then if you need to, you can put the, take some, lower the lights of the room, because sometimes it's overstimulation. Lower the light intensity of the room. Sometimes people can be put, I won't say by themselves, but put them in a place where the TV is off and the radio is off. We run into this sort of in nursing homes where people get put into very big rooms with a lot of people and the TV blaring and a lot of noise, and people get very agitated. But you take them out of that setting and put them in just something by themselves, and they're okay. Put them around things that they're familiar with, that they still remember. Again, talk in soft tones. So destimulation can help, and that can kind of help people calm down a little bit. That's the first and best thing you can do when people have behaviors. Now, what if they continue to have behaviors, could it be? Well, there's a couple things. First, there is what's called sundowning. Now, sundowning is a little different. This isn't just anxiety. This isn't just frustration. Again, frustration, you can kind of take them out of what's frustrating them. Just take them away from that situation. Sundowning is a specific thing that happens. We call it sundown because it happens near the sun setting. But honestly, a lot of times it's happening around 4 in the afternoon. And so it can happen, the sun's still quite a bit up at 4 in the afternoon, depending where you live and the time of year, but around 4 in the afternoon. So it can be where people start sort of hallucinating. They start losing contact with where they're at and what's going on and who's there and what's there. And because of that, they continue to kind of get very agitated and angry and hallucinate. And they may not even be aware of what's going on. They might see things. A lot of times with Alzheimer's, they don't see things. Lewy body, you might see things, but they will sort of react differently, and they'll maybe hallucinate a little, but will definitely act very differently and get very agitated. And it will almost always happen around the same time of day, 4, 5, 6, 7 o'clock at night. Right. Now, that is that's a concern. That's when that happens. Now, when you have that, people get very agitated, they get very angry. So the question is, what can we do to help them? How can we make them feel better? And there's a handful of different things people do. One of the go-tos that a lot of doctors pull out is antipsychotics. I have to be very careful with antipsychotics. Antipsychotics have side effects. All antipsychotics, the second generation ones specifically, have an FDA warning that says it increased the risk of strokes in people with dementia. Now, there is a new one that just came out, and forgive me if I forget its name. It's a fairly brand new one, and that did actually get FDA approval for dementia behaviors. I know, and another one that there was a handful of other ones that people would use, olanzapine, quetiapine, to help people with these behaviors. And those are antipsychotics. So those are meds you would use for someone who has schizophrenia in much higher doses. To put this in perspective, someone with schizophrenia might need 200 or 300 milligrams a day of Seroquel to help them. And maybe they don't need that much, but I've seen people need as much as that, sometimes 100 a day, to help control their schizophrenia. Someone with dementia, maybe I start 12.5 milligrams at bedtime. and then would increase to 25 if they need it, with maybe 12.5 in the morning. So they might need 25 to 50. So Seroquel can help a lot with that, with behaviors in people with dementia. There are other reasons you might use Seroquel. Some people with depression might need it, or Seroquel. I'm sorry, Seroquel is quetiapine. Seroquel is the name brand. I sometimes will slip between the two of them. It's no endorsement of the name brand, just me occasionally slipping between saying the two. Quetiapine or olanzapine. Again, olanzapine, you're going to be using a much lower dose than you would for schizophrenia. But people seem to calm down. They don't quite get as agitated and they can rest a little bit better at night. I will say sometimes I see people saying they use this for sleeping pills. And while sometimes what we do is we'll tell the patient with dementia, oh, we use it as a sleeping pill. It's a little white lie. We really tell the family it's to help their agitation. But they say, oh, it's your sleeping pill, Grandpa. Because it does make them tired and it does help them sleep. I don't advocate using that as a sleeping pill, though, for someone who doesn't otherwise have hallucinations or agitation or sundowning. Now, that's a lot of the standard medicines. There's been other things people have used, such as benzodiazepines, Ativan, lorazepam. Not a great choice. That can increase the risk of falls. It can actually cause a paradoxical agitation. Years ago in the hospital, people get agitated. The nurse would call the doc and say, can I get some Ativan? Can I get some lorazepam? I'm like, no. No, because older patients can actually get paradoxical agitation, even though these are anti-anxiety drugs. A lot of older patients can get worse agitation when you take those. So again, you got one drug that has some FDA approval for at least one of the drugs, and then a family of very similar drugs to that one drug that people use. But it has risks. It has side effects. And then you have another one that we really shouldn't be using anymore that sometimes people use. Sometimes people will just use a sleeping pill and Benadryl. Benadryl is the devil in older patients. It is a nasty little drug. It is over the counter. People, a lot of your over the counter sleep medicines, ZQuil, NyQuil, some of these will have Benadryl in it because it's extremely sedative and it makes people fall asleep and they're like, oh, but older people, it's anticholinergic, which means it decreases the acetylcholine in your brain. And acetylcholine is what diminishes when you have Alzheimer's. So if you have Alzheimer's and it's already diminished, and now you diminish it even more by using this drug, you've actually made the Alzheimer's symptoms worse. So sometimes people actually get more agitated and they will get hallucinations and they will get a lot more agitation. So Benadryl, not a good choice. Which leads to the question about what about cannabis? And the simple truth is we're dealing with something where there's not a lot of great options. And again, first of all, foremost, behavioral. If you can get someone just calm just by calming them down, do that. Don't use a pill. Like I said, the antipsychotics. Okay, but there are side effects to them. And then we talk about cannabis. And there are side effects to cannabis too in older people. This is not necessarily the best choice, but I think it's on the table. I think when you're talking about pulling out antipsychotics for sundowning, cannabis should at least be a discussion point. You can say, especially if the family says, well, I heard cannabis can help, because there are now several studies out of Europe looking at Sativex, where they gave people cannabis and their behaviors got better. Now, you're going to start super low. I had a family member once who told me they tried cannabis in their loved one with dementia. And they didn't ask me. They just had done it and then told me later. because they went and grabbed some gummies, gave it to her. I have no idea what dose. I just know that the poor lady slept for a day and a half. Maybe she needed to sleep, but needless to say, that freaked out the family. They never gave her cannabis again. And obviously, if you take cannabis and you sleep day and a half, yeah, that's not the right choice for you. But the good news is, unlike a lot of other meds, the side effects are probably not going to be long term. And I say probably just because probably, but yeah. The other thing is that there's not a lethal dose, so that's good. So you want to talk about that, but you have to be careful in older patients because there can be medical conditions. We talk about cannabis in the heart, and there's these studies about long-term use, can it lead to heart attacks and stuff. And then jury's still out on that because there's actually a really long-term study that's looking at heart disease that's been following people for 30 years, and they have a subgroup of people who have been using cannabis, and they haven't seen any yet, the Cardia study. But it's possible. It's not impossible. The other thing is that cannabis use can affect your blood pressure. So if you're someone who tends to have a super low blood pressure, cannabis might lower your blood pressure to the point that you faint or fall out. That's not a good thing. Conversely, if you're someone who has a super high blood pressure, cannabis might raise your blood pressure to something bad. If you have a very fragile heart and you're prone to heart attacks, maybe cannabis is not right for you. If you have a very fragile brain and you've had several strokes, maybe cannabis is not right for you, especially if your blood pressure is super high. At least what we know today about it. The other thing that might not be good is I saw this with dronabinol, which is the prescription cannabis, the over-the-counter, not over-the-counter, the prescription cannabis, the synthetic cannabis, Marinol, right? I gave that to people for their appetite stimulation to help them eat. And what did they do? Oh, sometimes it didn't work that great, to be honest. But the other thing is that I think some people got a little agitated because if you give something that makes them high and then they don't know it, if you say, hey, you have cancer and this will make you feel better, it's going to make you feel high, just so you know, so find a nice quiet place and chill while you take it. Most people could say, okay, sure, I know what I'm getting into. This is cannabis. I'm going to feel a little high. You give this to someone with dementia, they may not realize that this is going to be a side effect. And now all of a sudden they're like, and suddenly they're freaking out. They're completely freaking out because they don't know they're supposed to feel high, which is why I really recommend using doses that really don't cause that. In fact, you might want to try a little CBD first or something to see if that helps, and then titrate. And so for someone who's older, I would even start at the tiniest dose. Your average gummy is going to be 5 milligrams, and sometimes you can get a 2.5. I would cut that even further to a 1.125, right? A quarter of a quarter, tiniest little amount of a gummy, just a whiff, or a milligram if you have it in a tincture, just the tiniest amount to make sure they're feeling okay. And it's not going to work probably at that tiny amount. Just make sure they're okay and they're not having any side effects with it. Make sure their blood pressure is good with it. Make sure it's not going up too high, too low. Make sure they're not acting dizzy or anything. And then the next day or two, let them get used to it. Go to 2.5. And then you can go to 5, or you could even go up to 3.75 or something, halfway between the next dose, right? You can do another 1.12 and just go very, very, very slowly and look for side effects. Make sure they're doing okay. and then look for how they're doing. And when you find the dose that doesn't have side effects and it makes them feel better, that's your dose you're going to stay at. Now, if they're feeling bad and they don't have any benefit, then cannabis isn't right for them. If their blood pressure is crashing, the other thing you want to talk to with the doctor is make sure that you check all their medications and make sure there's no drug interactions with that. Cannabis can cause the liver to overproduce or underproduce chemicals that break down medications in our body. So every medicine we take goes through our liver, and then our liver breaks it down. Cannabis can affect the liver to increase that or sometimes decrease that. So you get too much of a medicine or too little of a medicine, depending on the medicine and which chemical it's interacting with. So you want to be careful about drug interactions. So not all of them are bad. Sometimes it's probably just increasing it a little bit. That's like, okay, if an antidepressant is 20 milligrams and the next dose is 40, and it's only increasing it to the equivalent of 25, that's not even clinically significant. That's not good. Your body is not going to be able to tell the difference between 20 and 25, and it's not going to hurt you. When you get into some of the more significant medications, warfarin being a big one, that's a blood thinner that is been used. It's used less and less now that we have some of the newer blood thinners out, but still there's a lot of people use it, and you have to measure levels on it. And taking something as simple as a handful of spinach can cause your warfarin levels to change. And it can go very quickly to a dose where it's not working, to a dose where it's toxic and you can bleed spontaneously. So it has a very quick hook and a very narrow therapeutic range. And so that's why people have to get their blood tested and make sure they're okay. Cannabis can affect warfarin. And there was some cases of people who used cannabis and warfarin together where the warfarin went sky high. But like I said, so can half the things you do with warfarin. So why not? It's not my favorite drug. But if you're on it, you definitely want to talk about cannabis and not having it used, right? You want to make sure that that's a situation where you think twice about using cannabis. Another situation might be transplant medicines. There's one of them, tacrolimus, can interact really badly. And they actually say tacrolimus, you can just check the levels and more frequently. Now, yes, you are going to have some older people who've had transplants who survived, and they're going to be on tacrolimus. Again, too low of a tacrolimus and you could go into rejection. Too high and you could get a dangerous infection. So you've got to have that nice little sweet spot. So again, that's a drug where the interaction is something I would not want to, I would not want someone to stress about. I would say, yeah, no, don't take cannabis with it, especially since your organ's dependent. So those are some types of different things with drug interactions. And I think I mentioned before blood pressure and stuff like that you want to be careful of. So when we talk about cannabis for older people, it's not, oh my gosh, yes, it's the best thing ever. It's, this is the risks. This is the risks of this other drug. This is the risk of doing nothing. Let's talk about what's the best option. And even though it's not, there's no guidelines recommending it at this point, I'd say based on a couple of the studies where we saw it did increase behaviors, improve behaviors in some people, that it's worth a try. It's certainly, Again, now, if someone's perfectly controlled and they're fine, please, please, please don't stop their meds and run off and buy cannabis. And please, please, please talk to your doctor before you do this and say, hey, we were thinking of doing this. And because you want to make sure, again, that there's no drug interactions or no real strong reason why you shouldn't. So you want to do that before you do it. But I think it's on the table. I think it's something to consider. Now, other side effects, right? Falls. Again, as I mentioned, a person, you want to try to find that dose that doesn't get them high, that doesn't make them really loopy or anything, but you can, the data shows there are some people who get dizzy, dry mouth. So now if you have someone who has a heart condition, again, probably not the person you want to be taking, but if they have a dry mouth and they're constantly drinking water and now their legs are swelling up, that's not a good thing. If they're feeling dizzy or they're falling, so if they're already prone to dizzy, if they've already had some falls, maybe not the best choice to do cannabis. If they have heart disease, as I mentioned, maybe not the best choice. If they have lung conditions, especially if you're talking smoking, right? Please, I would strongly also suggest that anyone with dementia not smoke cannabis. There's a whole thing about just smoking with dementia that people with smoking, you have these lifelong smokers. Let's just go to tobacco smoke. You have lifelong smokers and they inhale their smoke. And as the dementia goes, they forget how to use the lighter, right? They can use it. Oh, ooh, flame, pretty. I'm not joking. I joke, but I'm not. They light their cigarette and now they drop their cigarette. And now their cigarette gets on their clothes and it burns their clothes and they don't have the wherewithal to stop, drop, and roll. They don't have the wherewithal. There have been cases. There was an infamous case in a nursing home, I want to say in Chicago, many, many years back, where an elderly person took cigarettes, went out and smoked. They had dementia and they suffered third-degree burns and eventually died because that's exactly what happened. They dropped the cigarette and they didn't know what to do about it. Or the cigarette ashes, how you've seen people smoke and they just ash their cigarette, put it in a little ashtray. It ashes and the ash gets on them or something to that nature. And sometimes I've seen people with dementia. Okay, we really have to talk about this because they have cigarette burns in their clothing. And you're like, so smoking cannabis can be just as problematic for people with dementia. You don't want to just say, okay, let's save some money, buy a joint for grandma and have her smoke it. No, not a good choice because smoking can be dangerous, period. Now, you're smoking cannabis, equally not a great idea. The addiction in an older patient, probably not as big of an issue just because their lifetime and stuff like that is probably, you're not going to be titrating up the dosages too high. If you're doing this medically, if you're going to see addiction in an older person, it's probably going to be someone who's been using it their whole life. Some of my baby boomers, right, who started using it in the 60s and continued to use it. I'm not sure, the time I ran into an issue is when I had someone who was also smoking and they'd stopped smoking, but not before they had bad COPD and bronchitis. And so every time they lit a joint, they'd get a bad attack of their bronchitis and have to take the inhalers. And at least once they had to make an ER visit. I'm like, please, please, please use gummies. And as a doctor, I'm going to be saying use gummies anyway, because we don't like that whole idea of people smoking and making all that extra smoke that then gets into your lungs and does things But yeah, so, and of course, he was like, "Oh, I tried gummies, but they didn't work," and maybe they didn't. And this is where a conversation about maybe a different dose or maybe dry vaping, where a dry vape an herb might be better tolerated um, for for them. But that's a case where the need to smoke cannabis outweighed, the harm it was causing him. So, yeah, I would say addiction, if grandma's 80 and you gave her a couple gummies to help her rest and it's working. And I would say the other thing I would suggest is giving it closer to bedtime, treating it like you would one of the sedative antipsychotics, where you would give it after dinner or give it right before dinner, let them eat. And the perk to that, it might actually stimulate the appetite, right? So maybe you might give it right before dinner. Now the gummy is going to take a little bit to kick in. So, but you give it, and about an hour later, dinner kicks in, and now they're hungry. They eat their dinner, and maybe then they rest. But it's going to be at the end of the day, not at the beginning of the day when you might be taking them out to get their hair done or doing something else, or where they're out walking around. It's going to be the end of the day where they're already going to be sitting down and chill again. Because the other thing you worry about is falls. And that's going to be true for all of those medicines that we've talked about, every single one of them, and dizziness. And, so you want to just do that very carefully now. And, so yeah, no, you're not going to get, grandma taking a gummy at bedtime is not going to make her addicted to cannabis, you know, but, yeah, so, mm, I don't think we have too many people watching with us today. If anyone here is watching, feel free to sign in. Again, as usual, this is a live stream. We are here about you. I'm here for your questions. And while certainly I can talk an ear off and we can talk about a little bit more stuff, I do welcome you, if you're watching, to put just say hi. Start with that. And mm, make your name known, and let's just and pop up any questions that you may have. Otherwise, we'll keep talking. So, yes. Hmm. Now, the other thing I would say about gummies that a lot of older people need to know is that gummies, I mentioned for when we talk about doing it at bedtime, that a lot of times it takes a couple hours to work. The gummies actually now have different formulations. It's really come out of the beverage world that when people have cannabis beverages, that the cannabis beverages, so cannabis is oily and fatty. The THC is an oil. That's why people put it into butter or oil or things like that. It doesn't dissolve well in water. So a lot of places now you have cannabis beverages. You can go to the bar and instead of getting an alcohol, you can get cannabis. Now, please, 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 as a PSA, as a doctor, make sure you have a ride if you take one of those cannabis beverages. It might hit you harder than you imagine, and no one should be driving after having a cannabis beverage, because it might be in your system a lot longer. If someone might take a joint, it might take 2 or 3 hours, and you're like, oh, I'm going to be at the concert. I'm going to be at the bar for 4 hours. If I have one at the beginning, I'll be fine. But an edible might stay in your system for 6, 8 hours. It can sometimes absorb into your fat. And then as the rest of it gets processed, you'll actually get a second hit from the stuff coming out of your fat into your body as the rest of your stuff gets processed. The stuff that's sat in your fat now comes into your blood, and you might get a longer stay, a longer hit. So you may be intoxicated longer than you imagine. So please, please, please don't drive if you're using the beverages for several hours. I would say take an Uber for that night, sleep it off, and next morning, right? But if you, from that though, because those beverages are water, chemists and scientists have come up with different ways of what's called nanoemulsification, where you take the particle and you make it super tiny. There's a couple different ways you can dissolve it. There's about 2 or 3 different ways, and everyone will tell you that there's a superior. But what it does is it makes sure that in that beverage, in that can, every sip is homogenized, that you're getting the same amount in every sip. You don't have to shake up your beverage and like you would with vinegar and oil and before you drink it. You can just drink it like you would a beer, and it's going to have the same amount in it. And that process, what it has actually translated over into gummies. And so now you can take the nano-emulsified, the nano-encapsulated THC and put it into gummies. And what they found is it hits faster. Same thing with those beverages. They're probably going to hit faster. They're going to hit within minutes as opposed to hours. Because if you take a standard gummy, the message is, oh, it's going to take an hour or two. Certainly don't repeat it for an hour or two. And I would still say, if you have a beverage and you're not high, wait, right? If you have a gummy that's nano-emulsified and you're not high, I would still wait. Um, it just might be that particular brand takes some time. So yeah, be careful. But these nano-emulsified gummies, a lot of them will hit within 15 minutes and instead of 2 hours. And that's important to know because if you find that you go to the dispensary and you get a nano-emulsified gummy for grandma, for your mom or whatnot, and you say, I'm going to give it before breakfast, before dinner, well, you can give it 15 minutes before if it's the nano-emulsified one, and they'll be fine. Also, the nano-emulsified, the fast-acting, often will wear out of the system a little bit faster. So whereas a regular standard gummy might last 8 hours in the system, 6 hours, but in an older person, probably closer to 8, this might be 4 or 6 hours. So if you're trying to get something that's going to last the whole night. But on the other hand, if you take a standard one and they're sleeping to noon, maybe that nano-emulsified one might be a better choice. So that just to be aware that there's a difference in how the body reacts. We don't have any studies on those. I've seen some of the pharmacokinetic studies, how the body processes it. And all of the volunteers on these studies were in their 20s. So that's the other thing to know is we don't know how an 80-year-old responds to the differences in that. So that's why I say, if you get the fast-acting ones, you see it says fast-acting, and you say, it's been 30 minutes, it doesn't work, let's give another one. Don't, because we just don't know how that's acting in an older person. So just the next day, you can give a little bit more. Don't increase, don't give an extra gummy on the same day for an older person. Those are some of the things I would say about that. So yes, as we talking a lot, the mouth is dry. And so that's one thing to be aware of, is that difference. Now, other things with older people and cannabis use. Well, there's a couple other diseases and stuff that we talk about. I've talked about the Alzheimer's and the behavior, right? That there's some studies out of Europe, especially with the Sativex, that suggest it can help. And again, it's not FDA approved. let me put that huge disclaimer. Cannabis is not FDA approved, so nothing here I am saying is medical recommendation. Don't go running out and doing this. Go talk to your doctor first, as I've said many times before. But yeah, so that's that. Now, there's other diseases. There's some studies about Parkinson's that are kind of interesting. And again, this one, I would definitely talk to the neurologist first before I do anything about it. There are some people who swear that it can help their Parkinson's. And what happens, I think, is that the CB1 receptor does have some downstream effect in the dopamine, especially on the striatonagral area of the brain where Parkinson's is affected. And so it does seem to stimulate that, so it might be causing some increased dopamine. Now, what's unknown in someone like who might have Parkinson's when they're younger, right, is that what's unknown is does that hasten the development of resistance? Because I'm now giving it dopamine just like you do with the L-DOPA, and does the use of cannabis long term in Parkinson's increase the time that, or I should say, decrease the time that the Parkinson's meds work? Because the Parkinson's medications only work so long and then they stop working. And, many years, but still in a disease that you might have for a couple decades, that's an important thing because that becomes a very difficult thing once you start getting to the point where the meds aren't working as well. There was an animal study in Parkinson's, and God, I really want to see this in human studies, but we don't have this yet, of THCV, which is a cannabinoid that is non-intoxicating. And a lot of people are researching THCV because it blocks appetite. Uh, again, that's a whole other story, but the THCV, there's been animal studies where they did the model of Parkinson's, where they had animals that were modeled to be Parkinson's. And I told you that the dopamine kind of runs out after a while. The medicine stops working. You build up a tolerance and you can start getting these really uncomfortable side effects, these movement disorders, dystonias, these kind of frozen motions. Sometimes like the neck can be frozen or the different things can be frozen in a certain way. It's called a dystonia that can happen from the meds, and it becomes worse than the Parkinson's. And so what happens is they found that if you gave THCV with the Parkinson's meds, you delayed the onset of dystonia in the rats. So the bad side effect that meant you had to stop taking it, and the fact that the Parkinson's meds weren't working anymore. And if people even had, if rats had dystonia, and you just gave them the regular stuff until they got the dystonia, and then gave them THCV, it stopped. They did the rat study, the human study. If someone's doing it, if anyone knows of them doing it in humans, I'd love to hear about it and if there's any updates of what's happened. But sadly, that's one of these situations where we have the world's healthiest rats. And so, yeah, like I said, the world's healthiest rats. And that's the sad thing about cannabis, right? Is that we have, because of limitations of the legality, because it's not being pushed by big pharma, it's being pushed, well, it's not, and that's it. So research, people funding research doesn't happen. You don't get NIH, you don't get a bunch of NIH grants for this, and even for diseases that it could really help with, because it's federally illegal. And so the NIH ain't gonna, yes, there are some people who got some special exceptions and stuff, but generally speaking, it's not gonna be good. Then you have people, then you have, yeah. So human studies. You don't have big drug companies coming out and spending money on it. So we don't get a lot of people studies. And sometimes when they're done, because the funding is poor, because, a lot of times the studies done are drug maker X. I have my proprietary, I don't have Dr. Makela's cannabis, but if I did, Dr. Makela's cannabis, I could do a study. I could pair with someone and say, we're going to do a study on this, and we're going to do this, 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 and this. And I could even publish it. But the simple truth is, I don't have a huge amount of money, and most people don't. And so to spend on the money, to spend on the research. And as a result, the quality isn't good. I don't have the numbers of patients. To get a big study with a lot of patients requires a lot of numbers and a lot of people. And then to process all that data and to follow it for enough time to say, as opposed to a month, to follow it for 6 months to see how they're doing takes forever, all that time. So that money isn't there, not for most people. Because of that, the cannabis research is not great. Again, another reason I really want to see it legal so that we can get a little bit more funding from that. Whether it's from the NIH or from companies that might be more open to researching it. Because, yeah, I would want to see more about dementia. I'd want to see more. There's all these cannabinoids. So, as you probably know, there's 140 plus growing cannabis in the cannabis plant. There's THC, there's CBD, and then there's about 140 other chemicals in, plus they keep finding new ones in the cannabis plant. And each of them has slightly different things they do. They don't all act on the CB1 receptor. Most of them don't make you high. They do other things. They'll act on other receptors. Like some of them will act on a thing called the PPAR receptor, which is actually a receptor that some of the diabetes medicines work on. Some of them block, like THCV will block the CB1 receptor. Some of them will just stimulate CB2. Some of them will stimulate the hot pepper receptor, TRPV1, to then alter the effect on the CB1 receptor. So all of this interaction, so each of these drugs independently might be able to do something to tweak our endocannabinoid system to health. It would be great to learn about if any of these can do something specifically to treat a specific illness or ailment. But because, we're not seeing big pharma go after it, the people who can afford to do the studies, there's not too many of them. And so we don't get those studies. I would say that I would just say it's a shame. It's a shame. I mean, and the issue of not TRPV1, THCV and Parkinson's in the rat studies is a classic example because that's a real problem that causes real damage to people with Parkinson's and real harm. And in the rat studies, it's showing its help. But am I going to tell someone, oh my gosh, you go ahead and take this for the next 30 years because the rat studies say, no, I can't say that. Not like that. Not for 30 years. Now, if you already are at the end of things and you have the bad dystonias and your doctor's starting to say, can't take the Parkinson's meds. maybe it's worth talking to your Parkinson's neurologist about whether THCV would be useful to slow things down. THC, THCV, something like that. Talk to them a little bit about it. But yeah, that's not something I could just recommend, because the world is full of studies where it works for rats and doesn't work for humans. And, we do the rat studies because it kind of gets us in the right direction. But there's a lot of people out there who are advocating things that cannabinoids can do. And when you do look at it, it's just the rat studies. And it's a shame. Okay, that's my pitch on that. It is 3:55. I am really sorry that we didn't get too many people joining us today. I think I can see on the screen there that maybe we had one or two people pop up. But next week I will have learned my lesson, and I will be sure to split my invites up so that people know that we're not just going to be Wednesday, but we will be Thursday. And now, unless people are like, oh, no, Thursday evening is better, then we'll talk about whether or not we even do Wednesdays. But I will, if I don't see you next week, maybe I'll hopefully see a bunch of you guys tomorrow evening. I know I saw on the invites, I got a lot of RSVPs and a lot of people excited about Thursday evening. So that might be our new time. But I know we've had a number of people who have enjoyed coming on Wednesday to talk. So I will see that. Also, next week, I put a post up today. Next week, we will have I'm going to have a physician only. I mean, if you're not a physician, you're still welcome. But it's going to be mainly focused toward physicians, and it's going to be the 3 things that a physician should know about taking care of their patients who use cannabis. And we'll see, and I just want to talk specifically about that. Again, if you're not a physician, I'm not going to be checking your medical license and saying, oh, you're not a physician, you can't join us. You're more than welcome. But I'm going to be doing that on Tuesday at 3:00. I think it's going to be 3:00. If I get some feedback that people would rather have it in the evening, I might change it to Tuesday evening. But right now we're saying Tuesday at 3. And that will be less of a live stream and more of, a standard lecture. So more of a webinar as I talk about stuff and sort of give a lecture and whatnot. But I am so glad that if you guys are here, so glad you've joined me. Thank you guys. I hope you guys all have a great day and a great evening. Again, if anyone has any questions or anything that they want to join in on or a comment here before we go, I still have about a minute. But the other thing to know is I will be creating some lectures for physicians in the near future. If you know of a physician who can benefit from this, send them my info. If you are a physician and want to know more about lectures and how to care for people with dementia, not dementia, my tongue tied, if you are a physician and you want to know how to care about people who use cannabis, reach out to me. I will be doing some courses on this. One of the things is a lot of doctors are like, oh, I don't want to be a cannabis doctor. I don't want to rubber stamp this. And I've seen a lot of courses that offer that to teach people how to do this. But I am talking about if you just want to know what you need to know to care for your patients best, drug interactions, things to be concerned about. When is it addiction? When is it, when is it beneficial? When should we consider it? When should we not consider it? those types of very basic things, and then how to guide someone about dosages so they just don't go to the pharmacy, pharmacy, there's no pharmacy. They don't just go to the dispensary and grab whatever and have a bad experience. So I will be offering those lectures to physicians in the near future. I'm creating those right now, and I'm inviting any physicians who might be interested in this to reach out to me, and because I have some questions about what they want to learn, because I want to make the best possible series for people so I can make something that benefits them. And I want to hear what community physicians, because I know what I wanted to learn, but I'm a sample of one. I would like to see what other physicians feel like they need to know. And then I can create my lecture series to help them. Anyway, it is now the time's winding up. It's 4 o'clock. It is nice seeing everyone. I will hopefully see a whole bunch of people tomorrow evening for the 7 o'clock. And again, next week, we'll not only have the Wednesday and the Thursday lectures, but I'll have a Tuesday lecture just for physicians and anyone else who wants to pop in, talking about things you need to know about patients using cannabis. Okay, everyone have a great day. Stay well, stay safe. Take care.